o'clock in Jakarta and 6 o'clock in Australia. So good evening, Professor, Doctor, consultants, residents, and fellow. Uh, Today we are going to have our uh, Indonesian and Australia joint lecture series, which is held every month actually. But today is the topic is about vitreoretina. And thank you for joining us today. And this program is a collaboration between the uh, Faculty of Medicine, University of Indonesia, and Cipto Mankusuma Hospital, Kirana, with Lions Eye Institute, Perth, Australia. And today I'm going to be your moderator for this event. I'm Dr. Maria from Jakarta, and today we have a lecture from our professor in Jakarta, Professor Andi Arus Victor, which will talk about vitreoretinal interface disorder. And we also have a case presentation from Australia, which is will be given by Dr. Martin Hein. He will talk about case studies and clinical histological correlates of diabetic retinopathy. So without further ado, we are going to start the first session, which is a case presentation that will be given by Dr. Martin Hein. He is a PhD candidate in the Lions Eye Institute, Perth, Australia. Please, Dr. Martin Hein, present your case. Thank you.
Right, thanks, Mario. So I hope everyone can hear me well and can see my slides just there. So please let me know if you can't see anything.
Yeah, it's already visible.
Yeah, very good. Yes, I'm Martin. I've been sort of working as a doctor for the last few years, but for the last 2 years, actually, I've been doing my PhD full time at the Lions Eye Institute. And the sort of focus of my PhD is primarily around the sort of vascular complications associated with diabetic retinopathy. And we investigate that primarily with histological examinations of human donor tissues. So today I'll actually be presenting a case on a human donor that sort of came through, which had very bad diabetic retinopathy. And there's sort of a lot of lessons that we could glean by looking backwards at their case history as well, which we actually had a lot of scans and everything from as well. And these are just two images that you can see of actually neovascularization inside a sort of diabetic retina. So the case is of a 61-year-old lady who's a retired office worker, and she was essentially referred for a DR check by her optometrist after being sort of lost to follow-up for the last, nearly 8 years. The last note was in 2016, where she was noted as having some regressed retinopathy after having laser treatment. She's had diabetes, type 1 diabetes, since she was age 4, and has a whole host of microvascular and macrovascular complications of those diabetes. So including a renal transplant, a lot of toe amputations, and recently a stroke as well. And her chief complaint was essentially a diminishment in her right-sided vision. So if we have a look at her left eye, just on the Optos image, you can see there's a fair amount of laser there. And her vision is actually remarkably preserved. So back in 2016, it was 6.6, and now it's 6/7.5, and her pressures are normal as well. What you do see is quite a lot of subhyaloid or small pockets of subhyaloid hemorrhages around the mid-periphery and just temporal of the disc there as well. And when you sort of zoom in, you can see there's actually a attenuated retinal vein there as well, which isn't an uncommon find in quite severe diabetic retinopathy. When we look at the right eye, when we look at sort of the OCT of the same eye, you can see the correlating areas of the subhyaloid hemorrhages, and there's probably some degree of proliferative disease there as well. So you can see that in these two captures of the slices here. So this these sort of grainy structures above the retina are essentially correlating with those areas of small subhyaloid hemorrhages. And that's just a small cyst there, which has essentially almost been persistent since 2016. And the rest of the edema is pretty much resolved, which is good. And when we look at the right eye, you can see that she went from 6.9 to 6.15 over the course of 7 years. So not too bad. Her pressures are good as well. And the fundus image is remarkably, pretty much unremarkable besides all the lasers that she's had compared to the left eye. And again, you do see these attenuated and atrophied retinal veins as well. The OCT on the right side has a bit of edema, but that edema is sort of superior to the fovea and is probably far enough away that you wouldn't call it a clinically significant edema to be contributing that much to her vision as well. So I guess to summarize this case, she's likely had a mild progression of a proliferative disease since 2016. She's had an adequate amount of laser, and because her vision is quite preserved, there's sort of no current indications for any further therapy, such as anti-VEGF or anything like that. So the decision was made to have a sort of follow up within 6 months' time. And I sort of want to highlight that these sort of decision-making paradigms are really only made with structural imaging, and also macroscopic imaging of the fundus as well. No fluorescein or OCTAs were performed. So essentially, the status of the retinal microvasculature in a lot of these patients you're not too aware of. So the same patient actually ended up passing on 4 months later after this presentation with us, and that was from complications of a fall and end-stage renal failure. And we're lucky enough to have a Lions Eye Bank here attached to the institute, and they perform a lot of the enucleations primarily for corneal transplant, and they essentially give the rest of the eye to us. And that's what you can see here. So this is a donor eye with the cornea removed. And what we're doing actually there with those two devices attached to the back of the optic nerve is actually cannulating the central retinal artery and the posterior ciliary artery. And the reason we do that is because we can actually perfuse fixatives and certain antibodies directly through the vasculature of the retina and the choroid, so that we can get really nice images of these of the retina and study it in many different ways. And this is primarily what I'm doing for my PhD over the last few years. And after that perfusion is done, we can dissect the eye and cut out the retina and scan it under a microscope. And essentially you get really nice images of the entire vasculature of the retina. And that allows us to do a lot of really good studies. Typically in these types of investigations, you would be cutting out the retina first and floating it in a soup of antibodies. But the issue with that is that the retina is relatively thick, so you don't get complete penetration of the antibody into all vascular layers of the retina. Whereas if you perfuse the antibodies like we do, which is actually a technique that's been developed probably over the last 30 years by Professor Dao Yu and Paula Yu here at the lab. They've really refined this technique over the last few decades. It allows us to see really nice vasculature through all vascular plexuses. So, here I'm just highlighting that we do the central retinal and ciliary artery. And in that way, we're able to sort of superimpose the retinal vasculature and the choroid vasculature to sort of co-localize changes that you might see in both under varying conditions. And this is what you see when we dissected her eye. So you can see there's a normal retina, just for comparison, on the right there. And on the left there's the ischemic diabetic retina, which is from her right eye. And you can see that here. So this is the right eye that had the diminishment in her vision that was otherwise sort of relatively unremarkable. And if you actually zoom in here, you can see that there's quite a bit of macular ischemia, which isn't apparent just on fundus photography or wide field photography. You'll be able to see this on fluorescein, but it's not routinely done every now and then. So, and just for comparison, this is a more zoomed in image of the macula. You can see how enlarged the foveal avascular zone is there, especially when compared to a control eye, where the vasculature is very dense and very organized compared to this case of a diabetic macular ischemia. And having seen that, now that we've already assessed the patient the few months beforehand, you can sort of probably gather the picture that a lot of her diminishment in vision over the last 7 years was potentially due to the ischemia, actually. in the macula rather than any sort of other type of changes. And that's something that you don't really get an appreciation for until you do some type of microvascular imaging like OCTA potentially. This was her left eye. So there's a lot more preservation of the foveal avascular zone, which correlates with her more decent vision in that left eye. So diabetic macular ischemia, it's a pretty under-recognized complication of diabetes, which has a pretty significant visual impact, actually. There's a study by my boss, Professor Bala, who's actually looked into this. And you can see that he has a lot of direct correlations between the size of the foveal avascular zone as measured with the OCTA and also the visual acuity of the patient. Even in the context of diabetic macular edema that you can see here, there's some correlation there as well. And the sort of crucial element of this is that this type of ischemia is largely irreversible right now. And I think that's primarily because we don't really understand what's causing this ischemia down at the cellular level. And for that matter, we don't really understand what's happening to cause the peripheral ischemia you see in these eyes as well. And that's sort of one of the questions of my PhD that we're looking into with this technique that we have. So this is another ischemic eye that you can see. There's a lot of peripheral ischemia there, but this posterior pole is somewhat preserved. If you zoom into one of these areas of peripheral ischemia, you can actually see there's a vein and an artery bordering the upper left and lower right corners of the image. There's a lot of loss of capillaries, primarily on the arterial side. And if we zoom into the magenta or purple inset there, just that I highlight here, you can actually see that there's thickening of the endothelial cells that I outlined with that red circle there, which are nearly completely occluding one of the major arterioles leading to the capillaries. And just to the left here, you can also see that there's a thickened endothelial cell walling off an occluded capillary. So the thought is that these endothelial cells most likely thicken over time in relation to how dysfunctional they are in the setting of diabetes and probably contribute to this level of ischemia. So endothelial cells here are essentially just lining the inside of the blood vessel, and down at the capillary level, this is pretty much one endothelial cell thick, and there's pericytes abluminally to that, which are on the exterior surface of the blood vessel. And if you look at more images, it becomes more obvious. So this is a retinal capillary in an ischemic eye, ischemic diabetic eye, and it looks completely patent. But when you sort of cut it in half almost, you can see that there's a really thickened section of endothelial cells, which are nearly completely occluding the capillary. And eventually the hypothesis is that these endothelial cells thicken up so much to the point that they cause a complete occlusion and contribute to the ischemic picture that we see macroscopically. This is another example in a larger arteriole. If you look at the cross section there, it's not completely occluded, but it's just about nearly occluded through the thickening of the basement membrane, thickening of the endothelial cells, and also proliferation of the endothelial cells. So there's a lot going on in these eyes, which contributes to the ischemia, but primarily probably those endothelial cell changes. What we see here is another ischemic eye. But if we zoom into one of the major arteries right next, just temporal of the fovea, there's actually a sort of proliferation of endothelial cells directly within the arteriole, which travels quite a distance, almost 2 millimeters or so across the posterior pole, and it ends up sort of plugging itself into different arterioles, causing partial and complete occlusions as well. And if you look at this cross section, which is the white dotted line you see there of the arteriole, you can see this mass of endothelial cells is almost occluding the lumen of the artery by 50%. And these yellow and red insets just show that same proliferation extended towards arterioles and sort of almost plugging them, causing complete occlusion or partial occlusions within the macula. This is another example of just proliferated endothelial cells causing partial occlusions within arterioles. And what's quite interesting is that this sort of process seems to be occurring even in the setting of preclinical diabetic retinopathy. So by preclinical, I mean diabetic retinopathy before or diabetic eye disease, I should say, before the development of microaneurysms. So this type of endothelial dysfunction seems to occur far before that and probably contributes to some of the dropout of capillaries you see in preclinical disease. So that's the endothelial there, and the narrowing of the lumen, and also a patent lumen there in the control sample. And there's, of course, other mechanisms beyond just endothelia. Looking out towards the periphery, here we see a lot of cells in the magenta inset blocking up or nearly blocking up an arteriole, and also a bunch of different type of cell types. Most of them are probably monocytes or leukocytes, or lymphocytes rather, blocking up these major arterioles. So I guess diabetic macular ischemia and peripheral non-perfusion are sort of largely irreversible phenomena, which have pretty severe consequences for vision loss. And the mechanisms of the pathophysiology are essentially not very well understood. But our hypothesis is that this endothelial dysfunction sort of progresses to a point where they sort of decompensate, for lack of better words, and hypertrophy and swell and proliferate. And this sort of proliferation and hypertrophy is almost a major driving mechanism for the type of ischemia that we see. So because of that, prevention is probably key, because if there's already endothelial cells blocking up these capillaries, the chances that this is reversible is probably pretty slim. But there's always interest from the big pharmaceutical companies to find something which might be able to reverse ischemia. Thanks for your talk. Thanks for your attention.
Yes, thank you, Dr. Martin, for your nice presentation. I think it's very interesting, yeah, to have this very clear picture of histological profile of the diabetic retinopathy case, yeah, in this your patients. So I will open the Q&A session. If there is somebody who will ask about this case that have presented by Dr. Martin, please you may chat in the chat column box. Please, anybody. Before that, Dr. Martin, maybe I will ask about how did you see the histological picture in this? Do you use the electron microscope or what?
Yeah, so the method that we use is essentially a form of immunohistochemistry. So we perfuse antibodies that bind to particular structures, and those antibodies are essentially fluorescent, which means that if we put them under a particular type of microscope that shines a wavelength of light, it emits back an image. And in that fashion, we can sort of image particular structures that we're actually targeting to stain during that perfusion process. So it's essentially confocal microscopy with immunofluorescence is what we use primarily.
Okay, and did you correlate between the clinical and the histological picture, like in the non-proliferative and the proliferative diabetic retinopathy? Do they have the same profile for the ischemic feature, Dr. Martin?
Yeah, so in those more severe, more ischemic proliferative eyes, there's a lot more thickening of these endothelial cells and a lot more proliferation as well, even within the vessel is what I'm talking about of the endothelial cells. In the non-proliferative disease, there still is thickening of the endothelial cells, but to a much lesser degree.
Oh, I see. So the ischemic process is more likely in the proliferative diabetic retinopathy, right?
Yeah, I think it's more likely, but what's sort of interesting is that it still occurs even in those, very mild cases from what I've seen. Yep.
Okay, so it can it could occur in the earlier stage of proliferative diabetic retinopathy, right? Okay.
Yeah, or even before microaneurysms form is what we see sometimes. So these changes are potentially happening very early.
Okay. All right. Is there any comments from RSCM, maybe from Prof. Andi, Dr. Anggun, or Dr. From Jakarta? Any comments?
Yeah, thank you, Dr. Martin, for your nice presentation. I have one question. Is there any correlation or association between OCTA appearance and this histochemical that you report?
Yeah, so at this stage, the OCTA probably isn't good enough to see at the cellular level. There is a sort of research machine in the lab where, we try and get down to the most finest resolution to the point where we're able to see subcellular changes, but I don't think the OCTA is there yet. You are able to see the profile of the capillaries and everything like that, but in regards to these cellular changes, they can't quite see that just yet.
Thank you. Yes.
Yes, very interesting. Yeah. Any comments from other audience, or maybe any question to Dr. Martin? Okay, if there's no question, I think thank you so much, Dr. Martin, for your presentation. And we can proceed to the next session from Professor Andi Arus Victor, that will even talk about the vitreoretinal interface disorder. Dr. Prof. Andi Arus Victor is our professor in the Department of Ophthalmology, Faculty of Medicine, University of Indonesia, Cipta Mangunkusumo Hospital, Kirana, Jakarta. Without further ado, please, Prof. Andi, the time is yours.
Yes. Thank you, Dr. Mario, for the opportunity you give me to give presentation in this moment. On this occasion, I would like to talk about the vitreoretinal interface disorder. Sorry. Okay. As we know, the vitreoretinal interface is an adhesive sheet that connection to the posterior vitreous cortex of the vitreous body to the internal limiting membrane of the retina, and it consists of laminin, fibronectin, collagen type 4 to 9, and is those that act as an extracellular matrix glue. There are several conditions include in vitreoretinal interface disorder, such as posterior vitreous detachment, vitreomacular adhesion, if there is focal adhesion of vitreous phase within the macular region, and vitreomacular traction, if there is focal tractional distortion of macular area, and vitreomacular traction syndrome, if vitreomacular traction associated with loss of visual function, epiretinal membrane, macular hole, lameral macular hole, and pseudomacular hole. Yeah, according to the Blue Mountain Eye study, the prevalence of vitreoretinal interface disorder, vitreomacular adhesion around 33.6, and focal type 22%, and broad base 78%, and vitreomacular traction about 1.6%, and focal type 76%, broad base 24%. epiretinal membrane, 21.4%, full thickness macular hole, around 0.7%, and lamellar macular hole, around 0.7%. This is a picture of OCT appearance of vitreomacular adhesion A, which is adhesion of vitreous at the fovea without distortion of retinal contour. And B is vitreomacular traction with traction of the macular area and forming a cystic form. And C is full thickness macular hole and cystoid formation in the macula. And D is epiretinal membrane. And A is lamellar macular hole. And F is pseudomacular hole. As we know that posterior vitreous detachment usually in fourth decade of life, and in time the vitreous become liquefied, and we call synthesis, and become constriction and condensation, we call syneresis. Patients with posterior vitreous detachment usually complain about flutters and photopsia or flash of light. And we know that the risk factor of PVD is aging process, myopic eyes, inflammation, trauma, cataracts surgery, or intraocular surgery. This is the state of posterior vitreous detachment. State 1, if peripheral PVD with residual vitreofoveal adhesion. And state 2, if there is macular PVD with no vitreofoveal adhesion. And state 3, near complete PVD with only vitreopapillary atrophy remain. And state 4, complete PVD. There is one thing about PVD is anomalous PVD is defined as partial vitreous detachment with persistent attachment in the macular region. Anomalous PVD is the main factor for vitreoretinal disorder. Anomalous vitreous detachment with persistent vitreomacular adhesion could be associated with retinal break and detachment. If we have patient with PVD, usually we just observation and make a follow-up to rule out retinal break, because a complication of PVD, vitreous hemorrhage, retinal tear, and retinal detachment. Another vitreoretinal disorder is vitreomacular traction. And grading of vitreomacular traction, grade 1 is incomplete separation of cortical vitreous with persistent vitreous attachment at the fovea and internal lipinic membrane. Grade 2, grade 1, and either intraretinal cyst, cleft, or schisis. And grade 3, grade 2, and if there is subretinal fluid. If we have vitreomacular traction, usually observation in patient with good visual acuity. If visual acuity mild to moderate, symptom, the first approach is to observe for 3 months and re-examine using patients should be advised to perform periodic examination with Amsel grid or monocular reading test. And patient with visual acuity decrease and severe metamorphopsia and moderate symptomatic vitreomacular traction fail to improve with observation or progression of the traction, there's indication for we do pars plana vitrectomy. But there is no consensus on the level of visual acuity that should be considered significant, but usually a visual acuity of 6/12 hours is taken as indication for pars plana vitrectomy. Pars plana vitrectomy is used to eliminate anterior, posterior, and tangential traction and relieving the attachment of the vitreous from the macular area. Another kind is we use pharmacologic vitreolysis. We know that's ochriplasmin. If there is a small area of adhesion in vitreomacular traction and small or medium full thickness macular hole with vitreomacular traction. With pharmacologic vitreolysis, ochriplasmin success rate around 40 to 50%, and patient under 65 years, phakic, and doesn't have macular pucker or adhesion less than 1,500 micrometer, success rate is around 60 until 80%. And ocular adverse effect of ochriplasmin injection are vitreous flutter, photopsia, blurred vision, conjunctival hemorrhage associated with the injection, and potential for lens subluxation and retinal break. Another vitreoretinal interface disorder is epiretinal membrane. Another name is cellophane maculopathy, pre-retinal membrane, and pre-retinal fibrosis. Macular pucker. Epiretinal membrane, if there is a vascular or semi-translucent fibrovascular membrane on the surface of the retina. The sign is cellophane membrane. There is a retinal folding and macular thickening, and usually symptom patient complain of decreased visual acuity, metamorphopsia, and monocular diplopia. This is fundus appearance of epiretinal membrane and the OCT appearance. There is epiretinal membrane in the surface of the retina and detachment of neurosensory retina. The pathogenesis of epiretinal membrane, as we know that basically if there is posterior vitreous detachment with microbreak in internal limiting membrane, migration of retinal glial cell or FA cell into the anterior retinal surface, and accumulate for the cell proliferation. This is a grading of epiretinal membrane. Grade O, cellophane maculopathy, mild abnormality of the macular reflex, and grade 1, critical cellophane maculopathy, and grade 2 if there is macular pucker. Yeah. Usually, for patient with epiretinal membrane, in just observation, if there is mild visual acuity, because only small number of decreased patient during follow-up 2 until 4 years of follow-up. And if there is severe reduction in visual acuity, there is indication for we do pars plana vitrectomy. This is video of this is video courtesy by Dr. Anggun. Yeah, this is epiretinal membrane with pseudophakic retinal detachment. He did vitrectomy before put the encircling band and did vitrectomy. After that, he did membrane removal, dense membrane. He did membrane removal and then staining of the macular area, and he did ELM peeling. Because of a retinal detachment, put silicone oil inside. Yes. Another kind of vitreoretinal disorder is macular hole. We know that macular hole is anatomic discontinuity of narrow sensory retina that develop in the center of the macular area, common found in the people under 55 years or above, and more common in female. Global incidence currently is around 4 to 8 cases in 100,000 population. Classification of macular hole, we divide on primary macular hole, if commonly referred as idiopathic macular hole, and secondary macular hole caused by other pathologies such as trauma, high myopia, and surgical. For diagnosis of macular hole, we can use biomicroscopy as usual, but optical coherent tomography we know as a gold standard to confirm the anatomical hole, and for staging and management and prognosis. Also, OCTA confirmed the hole as closed after surgery, especially in gas filled eyes. This is classification, gas modification of macular hole. State 1A, if a yellow spot with loss of foveal depression, no vitreous separation. State B, yellow spot with loss of depression, no vitreous separation, but bigger than state 1. State B, a small full thickness macular hole with diameter less than 400 micrometer. And state 3, full thickness macular hole with diameter more than 400 micrometer without a vitreous separation. And state 4, a full thickness macular hole with diameter more than 400 micrometer with complete vitreous separation. Another classification according to International Vitreomacular Detection Study divided as vitreomacular adhesion, vitreomacular traction, and full thickness macular hole. Management of macular hole. If state 1, usually we observation, and in state 2, we can use pneumatic vitreolysis or vitreopharmacolysis, and in some patients maybe we can do vitreoretinal surgery. And for state 3 and state 4, we do vitreoretinal surgery. Indication for macular hole surgery if there is poor central visual acuity, worsening metamorphopsia, significant loss of visual field, macular hole state 2 or above, and full thickness macular hole. And gas tamponade we use air, but the closure rate lower because only 53%. If we use SF6 or C3F8, closure rate increase 97%. Usually SF6 used for small or medium hole if they are less than 400 micrometer, and C3F8 for large hole more than 400 micrometer. This is a vitreopharmacolysis we know as ochriplasmin or Jetria for intravitreal injection. Yeah, prognosis of macular hole is depend on the preoperative visual acuity, all size, and preoperative foveal defect, and duration of symptom. Yeah, this is again a prognosis of macular hole. Usually state 1 hole resolve spontaneously in 50% of cases. Early stage onset 2, 90% anatomical closure, and 80% improved visual acuity. Macular hole with onset more than 6 months, closure rate only 63%. Successful primary closure during initial stage will have best visual outcome. Reopening hole still has better outcome compared to macular hole that fall in primary closure. Another factor is the importance to measure of macular hole because this is important to know what is the prognosis. Macular index is quantitative parameter that can predict visual outcome and prognosis. Yeah, another sign is we call a foveal crack sign. This is foveal crack sign, hyperreflectivity line extending from ellipsoid zone to the internal limiting membrane. If we have the sign of this, potentially becoming a macular hole in the fellow eye. Our data from January 2013 until August 2017 in RSM hospital, macular hole closure 82%, and best corrected visual acuity improved 67%. This is one video for macular surgery did by Dr. Gita Lisa. Yeah, she did ELM peeling. Yeah. Yes. another video. Yeah, this is a refractor macular hole, a vitrectomy with ELM flap. Dr. Mario was done to this operation. He put the ELM inside in the macular area. Yeah, the ELM put to close the macular area. Yeah, another vitreoretinal interface disorder is lamellar hole. Is defined by the appearance of foveal via OCT. There is partial thickness defect in the macula, abnormal steep foveal contour associated with epiretinal membrane. And the other is pseudomacular hole. We can diagnose through the slit lamp biomicroscopy and usually associated with epiretinal membrane. Yeah, that's all my slide. Thank you very much for your kind attention for my presentation. Thank you.
Thank you, Prof. Andi, for your very interesting and comprehensive presentation about the vitreoretinal interface disorders. Now we are going to have Q&A sessions. So please, for the audience that are interested to give a question, please type your question in the chat box. Is there any comments maybe from Dr. Martin from Australia regarding Prof. Andi's presentation, or Prof. Bill Morgan? Any comments or question?
I was actually curious about the using the ILM to plug the hole there. What's the outcomes from that surgery?
Yes, please, Prof. Andi, maybe. Is there any?
Yeah. Our data not clear. Maybe Dr. Gita could help me about the result according to our result in Kirana Hospital for surgery of macular hole with the LM peeling. Dr. Gita or Dr. Anggut maybe?
Yeah, actually, maybe Dr. Martin, I will share screen, yeah, about my case. Can I share screen?
Yeah.
So I did some surgery with the pre-flap ILM peeling, Dr. Martin, and can you show my slides? Can you see my slides?
Yes, thank you. We can. Thanks, Mario.
Oh yeah. So this is first case. Yeah. There is macular hole. Yeah. This is the OCT preoperatively, and then we did the ILM free flap in this case, and after the surgery, the macular hole already closed, yeah, only after maybe 1 week after the surgery. So we did the ELM free flap in this case, and also the second case, This is a trauma case. The visual acuity is 6/45. And this is the preoperatively OCT. The diameter is 1,197 micron. So it's very large hole. And we did the conventional eye lamp peeling in this patient. But after the surgery, actually the macular is still open. And then we try to do the free flap and do the macular plaque, yeah. And actually it's closed, yeah. But we did not have the OCT in this case. I'm sorry, but actually it's closed. And although the visual acuity is not very improved, but I think the OCT is already closed. Dr. Martin.
Great, thank you, Mario.
Yeah, that's any more comments maybe from Prof. Morgan or?
Oh, no, it's just very interesting. Thank you. We see a lot of vitreal interface disorders. I think the prevalence of epiretinal membranes is huge, actually, and almost certainly those issues are going to be more common as we have people like myself getting older. So it's a very interesting presentation. I haven't got any questions or comments. I'm just very interested. Thank you.
Okay, thank you, Prof. Morgan. And maybe in the chat box, we already have some question from the resident. Maybe Prof. Andi can answer the question. Good evening, Prof. Andi. I would like to ask one question in regards to recurrent macular hole. What would be the best approach to manage this condition? Maybe Prof. Andi can answer the question. For the recurrent macular hole, Prof. What would be the best approach to manage the condition? Or maybe from Dr. Gita, Dr. Anggun.
Yes, as I've mentioned, the prognosis factor for the successful is preoperative visual acuity or size, size of the hole. So we have to measure the hole size. We have to confirm about the macular hole index. And duration of macular hole. If more than 6 months, usually have a poor prognosis. And the larger of the hole, the poor for close the hole. That's.
Yeah, thank you, Prof. Andi.
That is Dr. Mario, yes.
Any addition maybe from Dr. Gita or Dr. Anggun? Any other information or experience from Dr. Gita or Dr. Anggun? Yeah, actually, in my experience, also the duration of the symptoms also very influencing the outcome of the macular hole, and like the Prof. Andi already stated that the hole size also the macular hole index, Prof. Andi, it is also very important to be noticed before the surgery, so we can educate the patient how the prognosis will be and about the closure of the macular hole.
Yeah, Mario, if
yes,
there one question from Dr.
Dr. Kiara.
Yeah? If recurrent
Yes.
macular hole,
Yes.
yeah, like Dr. Mario did, yeah, we can vitrectomy again, yeah, vitrectomy again, and with ELM peeling, yeah, ELM peeling, and then put the ELM flap for that situation.
Yes. Yes, Prof. Andi. So actually, for the recurrent or persistent macular hole, we can do the free flap ILM peeling. Also, we can do the amnion membrane transplantation graft, yeah, AMT graft, or plug in the macular hole. Also, we can enlarge the macular the ILM peeling to in efforts to close the macular hole. Dr. Kiara or Dr. Sabita, yeah, Dr. Sabita who asked this question. Okay, any more addition from Dr. Gita or Dr. Anggun? Any experience about the macular hole, recurrent macular hole or persistent macular hole? Yeah, in large macular hole, we can use also the inverted ILM flap to close the macular hole. Yeah, so the technique is very also can close the large macular hole. Usually, I use the perfluorocarbon liquid to assist the inverted ILM flap peeling in the case of large macular hole. I think that's my comments or addition about in Australia. Dr. Martin, is there any difference or maybe any other technique that usually used to close the macular hole cases?
So I work a lot with Professor Ballarat. He does a lot of these surgeries. I've never seen him do the plug with the ILM, and I've not seen him peel under the PFO as well, actually. So no, I haven't seen those practices just yet.
See. Okay, yeah. I think because of time, I think we have to conclude this between Australia and Indonesian lecture series for this today. Thank you very much for your kind attention and also for joining us. Any announcement maybe from Dr. Mita as the coordinator?
Okay, Dr. Mario, usually we took pictures a bit. And Dr. Miki will help us to take our pictures. So I invite everyone who can open the videos. Please open the videos for a few seconds. Dr. Miki, can you assist us and take the pictures?
Yes, Dr. Mita. Everyone, once again, I would like to invite all of you to open up your camera as we will begin our photo session shortly. Okay, I think I will begin taking the picture now. Everyone, give us your best smile. 1, 2, 3. Okay, next page. 1, 2, 3. Third page. 1, 2, 3. Okay, that would be all, Dr. Mita. Thank you.